thank you. So in the next 20 minutes or so, I want to sort of pivot from what Scott was talking about and really continue that line of thought and sort of bring it into the clinic, into patients, which is really what our lab has focused on, and the Depression Center. The title of my talk is Discovering New Targets for Treating Stress Disorders. And in particular, I want to tell you about two targets and two sort of brief stories that hopefully are just the beginning chapters of actually moving towards identifying novel treatments. One story has to do with something called Kcmq channels, another with neuropeptide Y. These are my disclosures. There is IP filed around both neuropeptide Y and Kcmq channels. It's not commercialized or licensed. There's no income, but this is IP that's related to two of these things we'll be talking about today. Then the rest of the disclosure has to do with an institutional conflict related to ketamine, but I won't be talking about ketamine today. So this is the outline of my talk, and let me kind of just jump right in. So let me start actually with depression and just kind of start with this, sort of laying the foundation. This has been referred to as the world's greatest health problem. This accounts for more years lived with disability around the world than essentially any other medical or psychiatric disorder. This is, of course, before COVID. Depression is the most common outcome of severe or chronic stress, continuing from the discussion you heard in the prior talk. Just very briefly, what you see on the left is this is actually, this report is limited to looking at disability levels of all brain-based disorders. So this is all psychiatric, neurological substance, where the years lived with disability, that's a metric of disability at the population level, is shown on the y-axis. And so here bigger numbers are worse. And you can see here this blue line, this is by age, years lived with disability. This is depression in light blue, or depressive disorders that dwarfs everything else. This is it's hard to, I think, emphasize the global health burden of depression. Most patients who die by suicide suffer from depression, and we need to do better with treatments. There have been substantial recent advances in treatments for depression, but we have a long way to go. I will just make a note. I got this metric from a report in Nature from a few years ago on the bottom right. There is a lot of discussion. If you look at the disability and the public health burden of something like depression, and then the funding for biomedical research, it's really quite small. It's about 1/10 of the investment, for example, in cancer, another major driver of disability. That's from fiscal year 2013. But in any event, COVID stress, we are extremely, of course, concerned. And as Scott mentioned, I think pretty early on in the pandemic, as people started realizing what was happening, I can still remember when we shut the labs down in March of last year. I think I remember saying to the group that we thought we would be back in about 2 weeks. So I think it's hard to overemphasize the level of uncertainty, the way all of our lives have been disrupted. And for those people that were most vulnerable to things like anxiety and depression, that already had chronic stress in their lives, that had less resources, those have been the individuals that have suffered the most. So there's a tight link here between COVID, psychological stress, and depression. This is just a little bit of data that many of you may have seen. This is from a report in Nature from a few months ago. For example, just looking at the US population based on a survey during the pandemic, you see down here, bottom right, 44% of individuals were reporting symptoms of anxiety or depression, compared to about 11% around the same time the year before. So we're talking about a fourfold increase. So this is extremely concerning. I think we don't fully know what the effects of this essentially second pandemic of psychological stress will be. Just a little sort of med student primer. Most of you guys know this, but you know, so what is the effect? What's the link between stress and mental health? Obviously, that's a huge topic, but just to remind you, you know, we know that stress in and of itself is not necessarily bad, right? So what you're seeing is this classic curve on the right, where actually low to medium levels of stress, context appropriate stress actually improve performance. But then at some point, the stress increases either in its severity or chronicity, and performance starts going down. And again, symptoms of anxiety and depression are sort of the classic outcomes of that. And we can think about sort of this was adapted from the late Bruce McEwen, a review by him. His lab did so much in this area to understand just the biology of stress, but we're talking about everything from sort of chronic low grade and then to sort of the severe or life-threatening stress that we think of as more classically associated with something like, right, PTSD, post-traumatic stress disorder. And just to come back locally, what was happening in March, April, May of 2020 in New York City. So I went back to the Times and I grabbed this this data. The New York Times was tracking this closely. This is case numbers, hospitalizations, and death rates for New York City. And what you can see, peaking there about April 10th, we were averaging about 10,000 new cases a day. You can see the shape of the hospitalization rate around that time, April, and then this dramatic spike in deaths. And as you all know, the frontline healthcare workers bore, I would say, a unique brunt of this, in both simultaneously fearing for their own health and their families. Again, remember all the uncertainty. We didn't really understand how it was spread, what happens. So it was a very, very scary time, still is. But we know that the frontline healthcare workers are in particular a position of vulnerability, but of course, more broadly, the whole population suffering unprecedented stress related to COVID-19 and all the things like social isolation that came with the response to the pandemic. So let me shift now to drill down on this target I want to tell you about today, just briefly for context. So what are the illnesses we're talking about? We're talking about depression, anxiety, and PTSD. Essentially almost all medicines for these disorders, one way or another, increase either dopamine, serotonin, norepinephrine in the brain. So this is just a schematic of the serotonin neurons. These medicines work for many, many people, fortunately. They were discovered many decades ago through serendipity, and it's still the mainstay of medication treatment for these illnesses that complements the other primary form of treatment, which of course is psychotherapy and behavioral treatment. But there are problems, including a multi-week or month lag from the time someone starts the treatment until the time they actually derive benefit. This is a high-risk time, a time of risk of suicide in more severe individuals. And unfortunately, a significant minority of individuals actually will not derive meaningful benefit from these medicines. This is something I borrowed again from a Nature article some years ago, just sort of trying to take a step back. What are the different ways we can find new treatments for these disorders? So what you see here in the top panel, this is kind of the classic, sometimes called reverse translation. This is actually how we got to the majority of the treatments we have today. We observe an effect in humans. We sort of understand how it works in the brain, and then we can embark on, for example, the modern class of serotonin selective agents, were sort of engineered improvements in terms of side effects and things like that. But it really wasn't based on fundamental insights from neuroscience that you got a taste of, for example, with Scott's talk in the last section. And hopefully what I want to do in the remainder of my time here is give you an example of how we're trying to think about this, and really from the perspective of what are the fundamental effects of stress on brain circuits? How do we then measure that in individuals and people, and then use that as a platform to find new treatments? So fortunately for us, all of us, Scott did a good job of introducing us to this essential stress model in mice. This is the chronic social defeat model, and the basic insights that led to the clinical trial I'm going to tell you about really came out of Ming-Hu Han's lab, and many others such as Scott and Eric Nessler's lab have used this model to really understand what's going on in the brain and behaviorally in mice who may show what might be called a defeated or susceptible phenotype, or depressed versus resilient. And just to recall, there's an experimental mice that's exposed to a large aggressor day after day for 10 days. And then we can measure the multiple outcomes in the animal, such as social avoidance, that's time, social interaction test, and some other things that measure anhedonia, which is reduced response to pleasurable stimuli, and anxiety. And I want to drill down and tell you about just one sort of sliver of the biology of this as I've come to understand it. This is data that goes back to from Eric's lab, from Krishnan et al. In Cell 2007. So over here again, you see, so there was a question before about dopamine neurons and the reward circuit. The story's a bit complicated, but suffice to say for these purposes, following social defeat, right, the susceptible or sort of pro-depressant animals show an abnormal hyperactivity in these neurons, whereas the resilient or unsusceptible show essentially normal physiologic activity of these D2 projecting neurons from a fundamental a part in the brain, the ventral tegmental area, to this area that we've been hearing about, the nucleus accumbens, that you'll see me also refer to as the ventral striatum. And this shows this picture. And of course, a lot of work has been done at the epigenetic level and protein level and the functional level, understanding, well, why is it that, and how is it that resilient mice maintain a normal reward circuit, whereas the defeated or susceptible, depressed animals don't? And one thing that seems to happen is that the resilient mice have an upregulation in a particular family of potassium channels, which, if you remember, potassium channels signaling through there will tend to quiet down nerve cells, make them fire less. And so the theory is that this maintains in the resilient animals or unsusceptible relatively normal firing rates by virtue of more potassium channels compared to the susceptible. Okay, so why am I telling you all this? The insight from Ming-Hu Han was that, okay, so if you took, we know that in so-called resilient mice, they have, let's call it an upregulation or increased functioning of the specific Kcmq 3 channel, or what's called a 2-3 channel, because the 2 and the 3 heterodimerize. But what if you could give a drug to the mice that actually were susceptible to the stress that could mimic that? These are drugs that are called positive allosteric modulators, or Kcmq openers. They would bind to the channel and essentially make the channels that are there do more. And so this is work by Alison Friedman from Ming-Hu's lab. And just very briefly, this is exactly what they found, that across multiple different Kcmq channel openers, they could actually reverse a depressive phenotype in the susceptible mice. So this is just an example. Here, the drug is labeled retigabine. That's the same drug as ezogabine. It's known as retigabine in Europe. Scott told you about the target mouse, that a susceptible mouse will show an abnormal behavior of sort of hunkering down in the corner rather than normally exploring a conspecific non-aggressive target. With treatment here, you show this is a normalization of behavior. Same story in this classic, what's called forced swim test, where treatment with the Kcmq opener, retigabine or ezogabine, it shows an improvement in time spent immobile, which has been associated with antidepressant effects in people. On the right, this is an image used by courtesy from Mark Kaplan that very briefly just tries to basically boil down 6 years of research into the basic concept that if we can increase Kcmq function in brain, that may be protective against stress. It may be antidepressant. We can do that in people, and we can use a technique of functional neuroimaging to actually look and see, is this working through its effects on the same brain region, the nucleus accumbens or ventral striatum. And so that's what we did. We did a pilot study, but this is work through funding by the National Institute of Mental Health. This was just published in the American Journal of Psychiatry. I think it's ahead of print now. This is a proof of concept, the first randomized controlled trial this is in adults with major depression, 45 individuals that had depression, elevated anhedonia, and they were treated with this Kcmq opener, ezogabine, or placebo. The primary endpoint was actually changed from baseline over the 5-week treatment in the ventral striatum during a reward task, an adaptation of the classic monetary incentive delay task. And then secondarily, we looked at measures of depression, primarily the MADRS, which is a common clinical measure of depression, as well as measures of anhedonia. So what did we find? These are the results. On the left, you see a schematic of this version of the monetary incentive delay task that we implemented with collaboration with Emily Stern. I won't go through the details, but essentially, while the person's in the scanner, you can isolate brain activity that's during the conditions where the individual's told they could get a reward in the form of money if they perform correctly. You can aggregate all that on average, look at how people do at baseline before the drug and then after. And what you see on the right is the region of the human ventral striatum, which corresponds to the nucleus accumbens in rodents. That's been such a focus of the relevant circuitry for these behaviors, such as depression and anhedonia. Our hypothesis was that under treatment, activity should go up in this region. And what I didn't show you data on, but there's data that, as you might expect, patients with depression had abnormal activation or reduced activation of the system to reward. So we hypothesized that the activity would be increased. And in fact, this is what we saw numerically, although there was a lot of variation. This actually did not reach, this just missed statistical significance, but it was in line with our hypothesis that under treatment with ezogabine, at the end of the trial compared to baseline, there was an increase, and under placebo, there was essentially no change. Perhaps most surprisingly, we saw a very large effect on the clinical measures of depression and anhedonia. I'm showing you the depression measures here. On the left is the MADRS score here. This has changed from baseline, where negative numbers are good. That's the number of points you've improved. In general, a 10-point improvement is considered a fairly good benchmark. By the end of the trial, these individuals were exceeding 15 points better if they were treated with ezogabine versus about 10 with placebo. And this is a relatively large difference. And we saw similar measures with self-reports of depression, which is shown on the right. So this was very exciting. And this work forms the basis of a second trial we'll be doing with the support of the NIMH to explore this further. We simply put forward a very simplistic hypothesis based on this work, essentially that we might call it the Kcmq channel hypothesis of depression, and basically that at least some patients with depression have deficient signaling for one reason or another at these Kcnq 2-3 channels. Might be specific to the reward system. We don't know that yet. And the corollary, of course, is that enhancing signaling at these channels will improve symptoms of depression, perhaps specifically anhedonia. I know I went through that fast, but we don't have a lot of time, and I want to tell you about one more target. So I want to shift gears, telling you about our work with neuropeptide Y. Here, just on this slide, I want to pivot back to more of the classic stress or trauma of that we would consider, for example, something like PTSD. It turns out that neuropeptide Y is a circulating hormone which has been observed to be low in individuals that have PTSD. We're not sure if it was low before, but it's hypothesized to be a pro-resilient hormone. For example, work by Dennis Charney and others, I'm not showing here, but had shown that soldiers under stress, the greater their NPY level in the blood went up, the better they did under simulated interrogation. Here I'm showing you a classic study in the cerebrospinal fluid. Patients with PTSD have low NPY, okay, compared to healthy subjects. And there's a very large evidence base that essentially NPY is anti-anxiety and stress, basic stress models. And some of the regions that you heard about in the last talk, but are very important when we think about regions that register threat and fear. We're talking about, for example, the amygdala and its connections with the frontal cortex. These are regions that express relatively high levels of NPY. And again, it can be shown that, for example, direct injection of NPY receptor Y1 agonists can block the expression of fear or reduce fear learning. On this slide, I'm just showing you distribution of the NPY receptors in rodent brain. Again, showing some of these key regions that we care about. Like I said, I don't have time to tell you the whole story, but at Mount Sinai, we've been working on trying to figure out if we can get neuropeptide Y into brain, whether there's any signal that it could be effective for a disorder like PTSD for greater than 10 years. And there's a long story. There's many CNS conditions where we would like to figure out how to get peptides into brain, but it's not easy. They're broken down in the stomach. They don't go through the blood-brain barrier easily. There is something called the direct nose to brain route. And this is what we utilized for an initial study we did in PTSD, where this here, the artist is showing examples of oxytocin, similar problem. Oxytocin as a receptor, as a peptide, wanting to get that into brain, but the same concept applies for neuropeptide Y. So we partner with a company that develops a specific device to try to get particles up into the very top of the nasal cavity where they can actually have direct communication and migrate into the brain. And it's been shown in rodents can actually get into critical limbic structures like amygdala and hippocampus. NPY can when delivered in rodents through this direct nose to brain route. So just in my last 2 or 3 slides, I wanted to share with you a study that was published in the last few years of a randomized controlled dose ranging study in patients with PTSD. We had no idea, this had never been done before. We didn't know how much of this would get into the brain, what dose would be needed, but there was basic rodent work where we knew what dose would block stress in rodents, and then we could convert that to humans. And we ended up with a range here from all the way from giving 1.4 milligrams to 6.9. And individuals came in, were randomized to one dose or the other, all the way up to the highest dose. And the primary goal was to see was this safe. But we also looked for anxiety signals. And the way we did that was each individual came in on 2 separate treatment days, that's shown in panel A, and they underwent what's called a stress provocation procedure that I won't get into the details, but essentially it's a trauma script that's developed by the patient and the clinician ahead of time and then played back to them on the treatment day. And this reliably provokes symptoms of anxiety. And we treated them 30 minutes before with either NPY or placebo. This was a double-blind crossover study shown in A, and you see the timeline of, for example, the treatment at time 0, trauma script at 30 minutes. It takes about 1.5 minutes, and then we start getting symptoms throughout the rest of the day. So what did we find? First, we found that NPY was well tolerated up to the highest dose. We don't know how high we need to go, but we had a hypothesis just in terms of the efficacy that higher doses should show a greater benefit than lower doses on anxiety. And that's actually what we found. This graph basically shows the difference between NPY and placebo on one measure of anxiety that was significant, the Beck Anxiety Inventory. Here, more negative means there's more of a benefit of NPY over placebo. And if you fit a line, what you end up finding is that at the high doses, but not the low, there's a significant blunting of anxiety of NPY compared to placebo. Very preliminary. I should point out, there's only a few patients at each dose. This is not different than 0 at any individual dose, but there's a trend here. So we were excited. This was the first proof of principle that it was possible that NPY could be having an anti-anxiety signal in patients. This is my last data slide. This was just published. This is work led by Alexander Mate at the Karolinska Institute that we had the pleasure of collaborating on and supporting his research through collaborations, sharing our IND and other things. All the patients here were enrolled in his lab. He was interested in whether, very similar approach, used the same device, same manufacturer of neuropeptide Y. In this case, it was 6.8 milligrams. These are in patients with depression, and asked a simple question: was there a trend of reduced MADRS score within the first 1 or 2 days after treatment? What I'm showing you here in this graph is this is change in MADRS score. So now, the bigger the number, the bigger the improvement. Okay, this is plus 1 hour, 5, 24 hours, and 48 under NPY and placebo. What you see here is a trend over 24 hours and a statistically significant effect of NPY over placebo 1 day after treatment. By 48 hours, there actually was no difference. It should be pointed out that per protocol, the 48 hour is actually the primary outcome. So again, highly preliminary. These were 12 individuals treated with NPY, 18 under placebo. But another study in a different stress disorder in another country. So this gives us some hope that we really may have some traction with pursuing neuropeptide Y as a target. So let me just wrap up. So what I've told you about today, and again, this is well known, but we're very concerned that COVID is going to have far-reaching consequences in terms of the effect of stress on mental health. And these, what I'm calling stress disorders, depression, anxiety, PTSD, are already a major cause of suffering and disability. And I'm trying to, and the flow, I think, from Scott's to mine, and you'll hear the other talks, my pitch to you all is that we need new approaches that are based on neuroscience and understand the basic biology to really move the field forward. I've given you a little bit of data, and it really just examples that it could be that enhancing signaling at KCNQ channels within the reward circuit may be pro-resilient, may be antidepressant. I've shown with you a little bit of data that enhancing NPY signaling within the fear circuit may also be pro-resilient and anti-anxiety or anti-depression, and that future research really must endeavor to translate insights from neuroscience into actionable therapeutics for patients. So really enjoyed being able to present this work to you, and be happy to take questions.
Thanks very much, James. That was a great talk, and you know, super that this really looks that, you know, we may be having new drugs if you can get them in the brain, but you're working very hard for that. So actually there are 3 questions in the Q&A, if you can see them. I mean, there are 4, but the first one is just saying thank you.
Sure, okay.
Which is very nice. But if you can start with the one from Jill and work your way down.
Sure. Question from Jill: can NPY be measured in the blood or urine? It can be measured in the blood, and in fact, it is found. It does circulate in blood. The problem is that we don't think that NPY from the blood is really getting into brain because it doesn't cross the blood-brain barrier. So the typical metrics of, for example, you might want to know, you know, in that study, what was the blood level achieved, NPY. It turns out there's really not much of a correlation. It wouldn't be helpful because we don't think the drug is going from blood into brain. Urine, I'm not entirely sure about that. Actually, I don't think so. Okay. Next question from Ann Kush: does KCNQ based treatment target only VTA? Right. Okay, so I alluded to this a little bit. So when we give the drug, it goes everywhere in the brain. So what we don't know is where in the brain is its true mechanism of action. I can tell you, and the reason why we focused in on our measurement of the reward circuit in humans is because the work from Ming-Hu Han's lab, before they moved to the data I showed you, I may not have mentioned this, but they systemically injected ezogabine or retigabine or other drugs into the mouse to look at the behavioral treatment effects, because that was important for translation. But they've done a bunch of work showing that actually it is direct injection. They can directly inject the drug into VTA, into the circuit, and show that it's working in that system through those receptors. But there's a lot more we have to know about how exactly is it working in brain. This is sort of the issue sometimes described as off-target effects that we're always dealing with in medicine and psychopharmacology. Question from Alyssa: could one's exposure to early stress be impacting? So the answer is absolutely.
Okay, I mean, James, I think you have to really read it out loud, because otherwise people.
Oh, I'm sorry. Oh, I'm sorry. I forgot. Now I'm the only one that can read it. I'm sorry. Thank you. So yes, the question is, could one's exposure to early life stress be impacting the efficacy of current common pharmacologic interventions used for anxiety or depression in those individuals? So we think absolutely it can. And there's quite a bit of data that individuals that have suffered early life stress or maltreatment respond less favorably to commonly used medicines like SSRIs. So we absolutely. Good
All right, James. Thanks so very much. Again,
okay, thank you.
very inspiring talk with, clearly clinical implications.